angles to each other, and so the forces of that are exerted on the muscle cells by their contraction have to be dissipated in a lot of different vectors, and so the fibroskeleton helps to do that. The fibroskeleton prevents overextension, so you can't get too much blood in the heart. And when you have an increase in volume filling, you get more stretch of these elastic tissues, so you get a recoil of that's provided by the connective tissue with the contraction. So this elastic recoil is to help allow the heart to go back to a bigger volume so that it can start decreasing pressure and then start filling again. The fibroskeleton also isolates atria from ventricles. So events that happen in the atria are not going to spill over electrically into the ventricle. The pathway will be more or less unidirectional. But with pathology, we're going to find out that, yes, there are ways around and through this fibroskeleton, so there are alternative pathways for electrical activity. But most of the time, it's isolating the events in the atria. They're complete, and then there's the electrical events that be passed on to the ventricle. The heart in the chest kind of tilted at an angle, apex towards your left foot for the majority of people. Some people, their heart is turned to the right. It's called dextrorotation. Their heart functions just fine, pointed in that direction. But when you do an EKG on them, it's not going to look like the textbook because their heart is pointed and the electrical axis is pointed in a different direction. For the majority of people, the heart is pointed towards their left foot. The base, again, at the superior border, apex down here, kind of an oblique angle. And then the heart isn't facing square to you where the atrial and ventricular septum are dividing the heart to right and left halves facing straight out to you. The heart is rotated to the left. So the majority of the front of the heart in anatomical position is the right ventricle. The majority of the back of the heart is the left ventricle. It's then rotated around in that direction. So the interventricular septum is right under this fat and these blood vessels here. So you see a lot of right, and you see very little of the left, until you look on the back of the heart. And then you're going to see the opposite. You're going to see majority of the left ventricle and a little bit of the right ventricle. The blue color up here, red color up here, that doesn't mean your right atrium is blue and your left atrium is red. It's supposed to help you with understanding the oxygenation of the blood. So blue for veins, you have the superior vena cava here. It's going to bring blood into the right atrium, which collects venous blood. You don't see that on the back side of that atria. You also have an inferior vena cava. It's been cut, and so you don't see it. This line of fat right here is where you have your connective tissue septum that is going to separate your atria and your ventricle. So you clean off the fat and then you slice right here. You'll see this dense irregular fibroskeleton there. You also see in this more or less center, you'll see valves that are going to allow blood to go from the right atria to the right ventricle. There, if you come over here and slice on through this fat and into the heart, you're going to see a big, thick chunk of muscle. You're not going to see the fibrous skeleton because the fibrous skeleton is around all layers of the heart. So this area right under that fat and those blood vessels, that's your ventricular or interventricular septum. So the wall is the muscle cells. There's some more fat on this side. Can you follow the blood vessels around? That will separate the left atrium from the left ventricle. The right ventricle pumps into this blood vessel that divides to form pulmonary arteries. And what you don't see on the back side of the heart is that bringing blood back to the left ventricle are pulmonary veins. The vein and artery, those are directional terms. You can call this an efferent blood vessel, and coming to the left, those would be afferent blood vessels. Those are also directional terms. But the vein is a directional term, meaning it's bringing blood to the heart. So superior vena cava, vena means vein. Inferior vena cava means vein. And then on the side that's bringing blood back to the heart from the lungs, you have pulmonary veins. Still veins, but these veins carry deoxygenated blood. The ones that are bringing blood back to the left atria are carrying oxygenated blood. The blood vessels that leave the heart, you've got one that is colored blue, that is an artery, that starts with a large area called a trunk, and then divides into right and left arteries. This is also carrying deoxygenated blood, but now the blood is leaving the heart, so it's in an artery. Aorta is carrying oxygenated blood. It also is an artery. So arteries can carry deoxygenated or oxygenated blood. This depends on where they're coming from and where they're going to. So the right heart sends blood to the lungs to be oxygenated, and then and that's via an artery, and then veins bring oxygenated blood back to the heart. The bigger picture, that here helps to protect the blood vessels, and that here protects the blood vessels. This fat is over the interventricular indentation called the sulcus. We learned the term sulcus last semester in the brain. Whenever the brain invaginated, it formed the sulcus, and evaginated, it formed the gyrus. Well, we have sulcuses, sulci. This is a sulcus. This is also a sulcus, so collectively sulci. These are indentations in the surface of the heart. They contain the coronary blood vessels and also fat to protect them. This extension here of the right atrium, and there's another one over here on the left, those are called the auricles. Auricle, also over here you have an auricle. So these are little ears of the heart. They actually just provide a little more internal room for changes in the return of blood to the heart. If you have an increase in venous return, which is very likely to happen, you go and stand on your head over there, or you just go and lie down on the table, all of a sudden the blood that was in your feet is rushing back to the heart, so you have a huge increase in venous return by lying down or standing on your head. The right heart sees these large fluctuations in volume returning to it. Left, not so much. You compare the size of these expansion areas. Right has a big auricle, left has a lot smaller auricle. The left part is seeing blood returning from the lung. So if there's a large return to the right, then there's a large volume going out to the lungs. So when it gets to the lungs and then it's coming back to the heart, it's more regulated in the volume returning. The left heart doesn't see those large shifts in volume, so its atrium will have a smaller auricle. This little fibrous ligament here, ligamentum arteriosum, artery is the root there. This was part of the fetal circulation. The fetus is not breathing on its own. It's drinking the amniotic fluid and it's urinating into the amniotic fluid, but it's not going to be getting oxygen from the amniotic fluid. Blood is coming back to the right heart from the umbilical veins. And then it's going to pretty much bypass the lungs. One bypass is between the right and left atria, and the other bypass is here, between the pulmonary trunk and arteries and the aorta. So blood is bypassing the lungs. Some blood goes there to keep the tissues developing, but the majority are going to bypass. Once the baby's born and first time it goes, then the lungs fill with air and it becomes the path of least resistance for blood to flow. So now the right heart is sending blood to the lungs, and this connection will start to shut down. And when the large volume of blood comes back to the left heart, that's going to shut off the opening between right and left atria. So back side of the heart, mostly left ventricle, less of the right ventricle. More, another sulcus here, and more fat with major blood vessels going down there. This collection of blood here in what's called the coronary sinus, this will collect blood from the surface of the heart and then bring the venous blood to the right atrium. Here are your pulmonary veins. They're bringing oxygenated blood back to the left atrium, and here's your auricle from the back. The pulmonary arteries taking deoxygenated blood to the lungs. And here you can see superior and inferior vena cava. Inferior vena cava is running down the backside of the heart. So when they cut the vessels to remove the heart, you usually still see the superior, but you don't see the inferior vena cava. You could cut way down here and then you would see it, but most times they don't. Okay, I don't think my thing is going to work. It doesn't look normal. So here's the question. We just ask you, and you can hold up your hand if you're brave or not. This would be a quicker question. I have to get this bug worked out. We're flying upstairs. It doesn't want to work down here. Okay, so connective tissue of the heart. Is it A, consisting of areolar and dense collagen fibers? Is it B, providing a strong fibrous cross-linkage system, wrapping adjacent muscle cells together? Is it C, joining the muscle fibers to the fibroskeleton of the heart? Or is it A and B? Or is it A, B, and C? Okay, who says it's A only? Who says it's B only? Who says it's C only? Okay. Who says it's D, A, and B? Okay, we've got 3 votes so far. Who says it's A, B, and C? Okay. Majority says it's A, B, and C, and yes, it's A, B, and C. So it is areolar. Areolar is connecting the serous cells to the myocardium and the serous cells to the fibrous pericardium. So, and it also is dense collagen connective tissue in the fibrous pericardium, but also dense connective tissue in the structures that are around the valves and between the atria and the ventricle. It also is attached, allowing the muscles to attach to this fibrous skeleton. It's helping to anchor them, so they have something to pull against besides each other, so that the intercalated discs are not taking the full brunt of the muscle contraction. And it's also joining the muscle fibers to the fibrous skeleton. And you'll see that action as the heart contracts. The ability for the heart to rotate and relax, as opposed to kind of going at different angles to the fibrous layers, is due to the anchoring to the fibrous skeleton. So another question, the fibrous skeleton of the heart functions to maintain the shape of the heart, physically isolate atria from ventricles, help distribute force of contraction, reinforce the valve, all of the above. Okay, A only, B only, C only, D only, all of the above. Okay, so all of the above. Anterior and posterior interventricular sulci, which is plural for sulcus, on the outside of the heart. What is in there in those groups? Coronary arteries, fat, cardiac veins, grooves, all of the above are correct. So they only contain arteries, they only contain fat, do they contain cardiac veins, grooves, all of the above? Okay, all of the above. Okay, anatomy of the inside of the heart. Now we've cut the walls and we've taken the front of the heart off. So we've exposed the atria, we've exposed the ventricle. On the inside of the atria, we've got openings for superior and openings for inferior vena cava. We've got an opening that was once there, but it is no longer there. It's just an indentation. This is called fossa ovalis. It was foramen ovale in the fetal circulation. That was the way the blood bypassed the ventricle, which then would send it out to the lungs, and another bypass up here, your ligamentum arteriosum. So blood goes from the right atria to the left atrium, and it's bypassing the right ventricle. So when it's fetal circulation, when the baby cries and the blood goes out more to the lungs and then comes back to the left heart, you've got an increase in pressure here that then shuts this fossa. Eventually the connective tissue knits together and you're left just with an indentation. Here we've got a valve that is going from the atria to the ventricle. And this has 3 cusps, so it's called tricuspid. Cuspid means a pointed area. And we've got 3 of them on the right side. And if you come across to the left side, we've got a 2-cusp valve. It's called a mitral valve or bicuspid valve. This is called tricuspid valve. They're also called right and left atrioventricular valves. is just describing where they're located. Right side, left side, between the atria and the ventricle. These valves are anchored to part of the muscle wall. These papillary muscles are contractile myocardial cells. They contract at the same time that the walls of the ventricles contract. The purpose of their contraction is to put tension on these little white fibers that are called cordae tendineae. In other words, tendinous cords. The blood pressure is going to build up when the wall of the ventricle contracts in. First thing the ventricle has to do is close off the route back into the atria. If it doesn't, all it does is pump blood back into the atria. It will not pump blood out into the ventricle. The atria has just dumped its blood into the ventricle. It hasn't really filled yet, so its pressure is low, and the blood that's already out here that's been pumped by the last contraction has the pressure out in the aorta or in the pulmonary trunk higher than atrial pressure. So path of least resistance is from ventricle back into the atria. However, if your cusp is working properly and your papillary muscles are working properly and your cordae tendineae aren't broken, then when the ventricle begins to increase pressure, it's going to push the blood against the cusp, and they're going to move up to a horizontal position, and they will not open back into the atria because you've got this anchoring due to contraction of the papillary muscles, which are putting tension on the cordae tendineae, which prevent that collapse into the atria. So the cordae tendineae and the papillary muscles are controlling the position of the valve. The increase in pressure is going to push the valve back towards atria, but it will not open and let blood go back into the atria as long as the papillary muscles are working properly and the cordae tendineae are intact. Once that valve closes, and it will close on both sides pretty much simultaneously. So left ventricle builds pressure, closes the mitral valve. Right ventricle builds pressure, closes the tricuspid valve or right atrioventricular valve. Then it's still got to build pressure to exceed the pressures that are in the pulmonary trunk and the aorta. So it's going to continue to contract. When it finally exceeds the pressure that's in the great vessels, the pulmonary trunk and aorta, then these valves will open. They're called semilunar valves or pulmonary valve, and then up here you'll follow that arrow out and look behind the pulmonary trunk. You're going to see another semilunar valve, and that's the aortic semilunar valve. Once the pressure in the ventricle exceeds the pressure in the great vessels, those valves open. Blood leaves the heart. When the ventricle finishes contraction and the connective tissue starts to pull the ventricles open, the pressure is going to start to decrease in the ventricle. It's going to want to suck blood back into the ventricle. But these semilunar valves are designed so that that blood coming back towards them is going to fill them and they're going to snap shut. The outside of the semilunar valve is U-shaped. Blood comes back into it, fills it up, and then the three cusps will snap shut. So that's how the blood is prevented from getting back into the ventricle. Now the blood path of least resistance is out to the lungs via the pulmonary arteries, or out to the systemic circulation via the aorta. Interventricular septum. These muscle cells are contractile, but they're also cells that are modified to conduct action potential. And those are still named for the person named Purkinje. So this is not the Purkinje cells of the cerebellum. These are Purkinje, they call them fibers, but they're actually individual cells that are via gap junctions attached to each other and forming the conduction system of the heart. There are no nerves in this part of the heart. Nerves go to this area, nerves go to that area. Nerves can influence, but don't actually conduct electrical activity to the heart. The interventricular septum, part of it's contractile, but a lot of it is to get the action potential out to the rest of the muscle cells. The left ventricle uses the interventricular septum during its contraction. Right ventricle uses interventricular septum during its contraction. So it has two roles: contract with the left, contract with the right. Right heart, thin wall, so it doesn't generate as much pressure. Doesn't need to generate a lot of pressure because the lungs are highly vascular. They got a lot of roadways open in the lungs. So it's like when all the lanes of the freeway are open, you've got very little congestion. You've got a free-flowing automobile. The blood that leaves and only going next door to the lungs through all these open pathways doesn't need a lot of pressure pushing it there because it doesn't have any resistance out there in the lungs. It has resistance, but not very much. When you have to pump the blood into one blood vessel that is then going to multiple areas, and all those areas have a lot of pressure coming back because they're not dividing into open pathways very quickly, that it's distributed and then the pressure goes down. So these major arteries up here, the pressure is not dissipating by those branching of those arteries very quickly. The pressure here is pretty high. So left ventricle has to generate a lot more pressure to get blood out of it than the right ventricle does. So hence thicker wall of the ventricle. All these little columns of muscle, they're called trabeculae carni. Trabeculae or trabeculae is a column. Carni is meat. So these are the columnar meat on the inside of the ventricle. Various suggestions as to why they're there. Probably to generate the force of contraction in different vectors and also dissipate through the connective tissue those forces of contraction. Some people say it's there to create turbulence. The blood comes in and hits all these columns and becomes more turbulent and mixes the blood more efficiently. But anytime you have water hitting a blind-ended chamber, it's going to create turbulence. So it seems kind of a lame reason to have the trabeculae carni. Moderator band, shortcut for the right conduction system to the right ventricle. Some of the conduction goes down to the apex and then up the right wall, but some of it goes across and skips the apex. So it's a shortcut for the right part. We've cut now through the atrioventricular septum and taken the top of the heart off. We've taken the atria off. Now we're looking down at the cusp. We've have 2 on this side that makes a mitral or bicuspid valve, and then 3 on this side that makes a tricuspid valve. You have, if you're designing something and you want fewer leaks, do you put more moving parts or do you put less moving parts? Less. So a high pressure side of the heart, you've got bicuspid, you've got 2 moving parts. Lower pressure, tricuspid, 3 moving parts. Here we've got 3 moving parts for both exits from the ventricle. Aortic, semilunar valve, and pulmonary semilunar valve. So semilunar down here. Half moon shape, why their name. Here they're in the closed position. They're in the closed position when the ventricles are filling. The ventricle will have low pressure. The pressure in the ventricle has to exceed the pressure above the valve in order to open the valve. The valves are passive. When the ventricles fill, they have a lower pressure than the atria do. So they're sucking blood into them. At the end of their filling, the atria contract and push a little more blood in. But most of the blood got there already because the ventricle increased its size, which means its pressure decreased, which means now it's sucking blood into it. So the AV valves, the atrioventricular valves, are opening because the ventricle is sucking blood into it from the atria. So here they're in the open position. When the ventricles contract, first thing they do is close the semilunar valve. So the cusps have closed, and you can see that they're kind of bulging upwards. The artist has got a nice indication that there's an increase in the surface towards you viewing this picture. The blood pressure is pushing against the valve, but they're not opening back into the atria because of the chordae-tendineae and papillary muscle contraction. So papillary muscle is contracting, putting tension on the chordae-tendineae. The blood is pushing against the valve, but there's tension there, and the valve can only go so far and can go no further. So the first thing the heart does is close the right and left AV valve, and then continues to contract until it can exceed the pressure outside the semilunar valve and open those. Then the blood goes out either to the pulmonary trunk or to the aorta. Since this is left ventricle, it's going through the aortic semilunar valve. So first thing that happens, close the AV valve. And then keep the pressure building until you can open the semilunar valve. Then blood goes to the lungs, blood goes to the systemic circulation. All of this around here and connecting together, this is what you can see as fibrous skeleton. It's connected to all the fibrous connective tissue that's around all the layers of the muscle and around individual muscle cells themselves. We've got a firm anchoring of all this muscle to this skeleton that you can visualize. You look at the aortic valve, high pressure or low pressure? You're going to be seeing high pressure or low pressure? Aorta. Left ventricle pushes to aorta. Thick wall, thin wall. Thick wall. Thick wall generates low pressure or high pressure? High pressure. So aorta, aortic semilunar valve in the center here, sees high pressure. It's attached to both AV valves. It's attached to the pulmonary valve. It's supported on all sides by this fibrous skeleton. Pulmonary semilunar valve, high pressure or low pressure? low pressure. It's anchored only to the aortic valve. It has a thin ring of fibroskeleton around it, but since it's low pressure, it doesn't need all that tethering to stabilize it. It's got a, not shown here, but a thick wall of fat right on top of it, and that's connective tissue, and then muscle that's helping to stabilize it. Trigones, three-sided, so we've got relative three-side here, three-side here, three-side here. On this side, we call it right fibrous trigone. On this side, we call it left fibrous trigone. These are just these triangular shapes of the connective tissue that help to stabilize primarily the aortic semilunar valves. Conus arteriosus, that's what is supporting the pulmonary trunk from the front. Okay, question. What's the function of the moderator band? Pacemaker of the heart, anchors the chord tendony, creates turbulence to mix blood, provides a shortcut for the action potential from the right margin of the heart to the right margin of the heart, allows venous blood from the heart to access the right ventricle. Creates turbulence. Okay, provides a shortcut for action potential. Yes. So blood vessels on the surface of the heart, but these are also branching and going into the nucleus part. We'll go back to that section of myocardium and see where these are ending up. Two main blood vessels are the first branch off the aorta after the semilunar valve. So the aortic semilunar valve opens, blood rushes out into the aorta. As soon as the ventricles relax, blood comes rushing backwards, closes the semilunar valve. The blood doesn't go into the ventricle, but it goes out into the coronary arteries. Can the coronary arteries fill during the left ventricle's contraction? Who says yes? Who says no? Two brave people say no, and they're right. It cannot fill during contraction because the muscles are pushing inward. So they're going to create more pressure in the coronary arteries than the blood. And the blood is also rushing very quickly past them. So when the blood comes back towards the ventricle, the heart is going into its relaxation phase, but it's not pressing on the blood vessels, and then the blood is going back and hitting the cusps, which puts pressure, increases pressure that can then fill the coronary artery. Got a left and a right coronary artery. Main branches follow the interventricular sulcus to the right, and then a branch goes down the right margin of the heart, continues around to the back of the heart. So this is the marginal branch of the right coronary artery, and then we've got coronary artery going around to the back. Left first branch goes down the interventricular sulcus. It is descending, so various names for it. It's on the front of the heart, so it's anterior. It's on the surface of the interventricular sulcus, so interventricular, and some people even say descending. The arteries don't go upward, but anyway, some people say descending. Branch of the LCA, or left coronary artery. Second branch is circling around to the back. It's called circumflex branch. So know the main arteries and be able to identify them. If you go to the back of the heart, you can see the right coronary artery is coming around to the back, and then it will descend in the posterior interventricular sulcus. So that the same posterior interventricular branch of the right coronary artery. So marginal branch seen here, and then the continuation to the back of the heart. Circumflex comes and then descends on the posterior side of the left ventricle. So posterior left ventricular branch of LCA, left coronary artery. The veins come back here. We've got venous blood going in the opposite direction. So great cardiac vein on the front of the heart, and small cardiac vein from the side of the heart. On the back of the heart, we've got middle cardiac vein, and then we've got posterior vein of the left ventricle. These big superficial veins are all bringing blood into this kind of area that's holding on to the blood until the right atria goes into its relaxation phase. So this is called coronary sinus. Sinus is any dilated area in anything. Could be a bone, could be a blood vessel, and could be a capillary, could be a vein, could be an artery. We've got carotid sinuses. Here it's a coronary sinus. The coronary sinus, used to they just thought, it's there to put blood and allow it to be in a holding pattern until the atria is finished contracting. So now they're looking at it, it actually has a muscle that extends from the atria into it. So it's got that. It also, if you want to get access to the heart, you can use the coronary sinus. If you're going to go in there for ablation, you've got cells that you want to kill off because you've got tachycardia, and can access those cells from the coronary sinus. Sometimes they're a problem themselves because they have myocardium. Then they form sleeves around this area. They can actually be a source of the the atrial tachycardia, and it can be a site for re-entry of contraction, action potentials. So it can be a problem, but it also can be clinically useful. The blood vessels up here, these pulmonary arteries, they also have myocardial sleeves around them. Kind of makes sense because they are directly going into the left atrium, and they're bigger, so they have more muscle, and they actually have, they're more likely to be a source of ectopic muscle action potentials or re-entry pathways. So here's your conduction system. We'll pick up with that on Thursday.